You are welcome to my channel, still on respiratory failure. The topic for you today is type 3 respiratory failure. Without further ado, let's go. Definition of some terms. What is respiratory failure all about? Normally, we'll inhale oxygen and exhale carbon dioxide. But in respiratory failure, that has become impaired. Not many people will be ventilating fully. That is a sign of respiratory failure in them. And anyone with that impairment will likely be faced with decreased oxygen supply to the blood and consequently decreased oxygen supply to the tissue, otherwise known as hypoxemia and hypoxia respectively. But we will not suffer that alone because we will be subjected to metabolic derangement. And at that point, kidneys will be recruited to help us out. Why that? Once there is decreased oxygenation and increased carbon dioxide retention, the pH level will drop, and that is known as respiratory acidosis. Further drop in pH or badly drop in pH is detrimental to the health of anyone. But the system has a way of handling that if it's still within the reach of the body itself. That is why the kidney will have to come in. The kidney will help us in pumping bicarbonate into the system, finding the way to compensate. That is all about the definition of respiratory failure. We are no longer meeting the body requirement as per oxygen intake and carbon dioxide exhalation. Type 1 respiratory failure has been fully defined and published. You can go through this link to listen to that, please. Type 2 is all about hypercapnia, that is, retention of carbon dioxide. Carbon dioxide is high in type 2 respiratory failure. That has been fully defined and also published right there. Today is all about type 3 respiratory failure. And I will not waste your time here because I will go deeper in the next few minutes. Finally, type 4 respiratory failure is about shock, leading to hypoperfusion. Shock as a result of septic shock, cardiogenic shock, hypovolemic shock, shock of any reason that has gone bad to the point of affecting all organs, also known as decreased organ perfusion or major organ failure. In that case, if shock is leading to organ failure or multiple organ failure and the respiratory system is affected, the failure at that time through shock affecting respiratory system is type 4 respiratory failure. Now, type 3 respiratory failure proper. This is all about surgery. It is related to the time that a surgical procedure had been carried out. After the surgery, post-operatively, respiratory failure that occurs will be tagged type 3 respiratory failure. That is why some authorities will put it as perioperative respiratory failure, meaning around the time of operation. It is a subtype of type 1 and type 2. Then you may ask, if that is the case, why a different name? A different name became necessary because this became so common that around the time of operation, respiratory failure may occur, and that is tagged as type 3 respiratory failure. Here, our problem is lung collapse, known as atelectasis. And that will be as a result of functional residual capacity depletion or reduction in volume. And we will get into that trouble after the use of anesthetic agents, like generalized anesthesia most of the time. Then, as a result of pain, of course, we know that anyone who had just gone through surgery might be in pain. And also as a result of abdominal mechanisms, or there is ascites present. In summary, here it is all about perioperative atelectasis that is due commonly as a result of the use of anesthetic agent. And it is because the functional residual capacity will drop. In fact, the positioning of the patient could also lead to a drop in functional residual capacity. Don't worry, we'll get into details in a bit. Hence, the lung, the unit of the lung in that particular part will be affected. It will collapse, and that is atelectasis. And when that has occurred, then we are dealing with type 3 respiratory failure. I will explain further why we can get into trouble with functional residual capacity giving us atelectasis. Let's go. Like I promised, okay, let me fulfill that right now. So let's go into details about functional residual capacity. Some will just summarize it as the volume of air remaining in the lungs after a normal passive expiration or normal passive exhalation. But to really get into the full meaning of functional residual capacity is more than that. Functional residual capacity is the combination of residual volume and expiratory reserve volume. I will define each. The functional residual capacity is about 3 liters, and the component that is residual volume is the amount of air remaining in the lungs after a normal respiration, passive expiration. This cannot be exhaled, and it cannot be measured with spirometry. This is responsible for keeping alveoli open, thereby preventing collapse, so preventing atelectasis. You can see that we will now understand more when this FRC is low. We can then get into trouble with lung collapse. So when this is okay, then we may not run into lung collapse. Now, expiratory reserve volume is the air that can be exhaled forcefully after a passive exhalation. So combination of these two will form functional residual capacity. Also, when it comes to type 3, we need to understand that there are 2 other forces that should be considered. The 2 forces here are at equilibrium. Now, the forces here are such that elastic tissue of the alveoli has inner recoil capability or force. Then the second force here will be the chest wall that wants to expand. So here is the explanation. The alveoli elastic tissue will like to recoil, shrink, while the chest wall will like to expand. So if you go too much of expansion, you know what is going to happen to the lungs. And if it's recoiling and it's not expanding back, you know what that will mean. So in this case, both the recoil and expansion must reach a midline. And when that is done, that will prevent the collapse or busting of that long unit. So that is important. Let's note this, that low level of FRC means that the capability to prevent lung collapse is lost. It is lost. Once FRC, functional residual capacity, is low, then atelectasis is at the door. Now, let's go through the possible causes of type 3 respiratory failure. By now, you are familiar with the fact that it is perioperative, and the individual in this trouble is likely someone who has just gotten out of surgery and recovering right now. Okay, so the first agent to be considered would be anesthetic agent, particularly general anesthesia mostly. Well, if regional anesthesia is the case along the chest region, that might be abdominal surgery or surgical incision could be another cause. And of course, depressed cough reflex might be responsible. I have gone over the importance of functional residual capacity. So anything at all that will reduce functional residual capacity could be the culprit, including positioning. And that is why supine positioning will be a big factor as a causative condition here. Then, something that we can easily ignore but pretty easy to find out is airway secretions or not. So airway secretions could be responsible. And when the abdomen is examined for ascites, if that is picked, that might be the cause of our problem. And then we can see that when body mass index is done and we physically check the affected individual, it's likely that the person is severely obese. So now, what are we going to do in this situation? Well, when it comes to treatment or intervention, first thing first, we must check the airway and sanction the secretions if found. Then we must observe any post-operative patient very closely. All units involved will definitely take that into consideration. In other words, we don't send the patient into the ward so quickly. Then, before involving anyone, once this is the issue, we'll get oxygen and administer as it is required. Incentive spirometry will be helpful, and chest physiotherapy is welcome. Now, when we were going through the possible causes, lying supine was given as a condition that would decrease functional residual capacity, and that will lead to atelectasis. So in this case, we have to be turning the patient frequently. Within 2 hours, we can be doing that. Why that? We want functional residual capacity to remain high, because functional residual capacity is highest when the patient is upright, upright positioning, and lowest when he or she is laying supine. Then we have to give adequate analgesia, because pain could be responsible. When someone is in pain, he or she is afraid to even breathe in and out. Ventilation at 45 degrees in upright position. You see, I'm emphasizing positioning because it is the simplest maneuver we can do to help the affected individual to get out of type 3 respiratory failure. And lastly, we have to look for, and once we're able to identify any cause or causes, we must treat appropriately. For example, if ascites is picked as the culprit, then we must drain. And then we don't overhydrate. When we overhydrate, we might run into pulmonary edema. And when that is the case, we look for iron-sealing diuretics like furosemide, also known as laces, to send the fluid out. Then we'll re-expand and prevent the collapse of that very lobe. So with this, I've come to the end of this short presentation on type 3 respiratory failure. It is all around the time of surgery, perioperative. And we have gone through what we could do to prevent this. And if we are unable to prevent it and the problem is there, we know the first thing to do. And if we have done all this and we are not winning, we should call the appropriate department. The surgeon that carried out the operation, everyone involved, the department of anesthesiology, then everyone involved, the pulmonologist, they will all help. Thanks for listening. Remember to subscribe to my channel. I appreciate it.